Hello, hello, and it is Wednesday, a Wednesday in April. I'm so happy to join you here today. It is Functional Neurologic Disorders Awareness Month. You all know this is a very big topic that we're passionate about, so we are going to be going live almost every day this month to talk about functional neurologic disorders. If we haven't met, my name is Julie Hirschberg. I'm a neurologic physical therapist and the owner and founder of re+active Therapy and Wellness. I'm in the Los Angeles area today, and I wanted to share, let me share an image here, a recent Scientific American opinion piece that I am just absolutely in love with. This is written by a neurologist and it is fantastic. Get your hands on this. You can, it's online. I'll put it in our newsletter this week, but it was called New Research Points to Causes for Brain Disorders with No Obvious Injury. The subtitle here, Functional Neurologic Disorders are very real and medical compassion is an important part of treatment. This is by far one of the best pieces that I have read on FND, and it's concise and clear and talks about some of those basics of FND that I think are so important. So for today, I really kind of wanted to do FND basics. FND is real. So this is also based on some of the questions that people have sent me, which, by the way, if you've got questions on FND, send them my way. This month, we're going to be going live. I'll want to answer your questions. So let's start with the very basics. What is FND? What is a functional neurological disorder? And it is actually very much what it sounds like. It is a disorder where it's in the functioning of the brain that things have gone awry. So when I think of functioning in the brain, I think of connections, connectivity between different areas. And honestly, that is what they see in the research in functional neurologic disorders. There seems to be heightened connectivity between areas, certain areas of the brain, and under connection in other areas of the brain. So it is a disorder of functioning of the brain. Now, some people, like in this article, they say new research points to causes for brain disorders with no obvious injury. So I think when you think typically about brain disorders, you think of a tumor or a stroke, and you think of an MRI where you can see that on the image. And one of the distinguishing factors in FND is that on a typical image, on a typical MRI, you're not going to see a distinct lesion or an obvious injury, as this author states, which I think is a fabulous way to state it. So that is what is functional neurologic disorder. I highly recommend this article. I also recommend neurosymptoms.org. If you're new to this and haven't seen it, fabulous website explaining functional neurologic disorders. Now, what might this look like? Just like other neurologic disorders, there are typical presentations here. I'll stop sharing this for a moment. So what might FND look like? So it can look like tremor. That's the most common symptom. It can be dystonia. It can be weakness. It can be seizures. It can be loss of vision. That's something that we've seen. It could be sensory symptoms. So there's a lot of very wide variety of symptoms that you might see in functional neurologic disorders. Now, one of the things that this author speaks about in this opinion piece, and this is in the literature as well, is it is very challenging for clinicians to understand and to diagnose this disorder. And that is very frustrating. That is why we talk about FND so much, because I want to empower clinicians with information and knowledge about FND so that they can be helping people get better instead of making it worse by not understanding it. But why is this? And actually in this paper, I thought they did such a great job of going through briefly the history, but essentially FND, very unfortunately, has a very long history and stigma and misunderstanding surrounding that. Way back when, it was called hysteria, and they would think that women had a wandering uterus in their body. I mean, just totally not logical now, because we know people's uteruses, they don't wander through their bodies, right? So when you have imaging, when you have techniques to find these things, you kind of can prove them wrong. So hysteria, it got proven wrong because we understand that that doesn't occur. So when there are things that don't fit patterns and we don't have a pattern to explain them, people will tend to put them in these buckets, right? So medically unexplained symptoms, for example. Well, much more has been done now to actually understand the symptoms. So what was understood as hysteria and then conversion disorder, meaning, I'm not sure if you know this background too, meaning that somebody would have a psychological mechanism and it converted to something in their body like tremor or weakness and things like that. We know now that is not solely the reason for functional neurologic disorders. We do know that psychological mechanisms can contribute or be a part, or for a certain subset of people be the issue, but that is not really how functional neurologic disorders are now understood, because we have research and imaging, particularly fMRI, to better understand the mechanism. So let's talk about the mechanism very briefly. And I'm going to share an image here, actually, if I can, that in that Scientific American article, they reference another article in Scientific American from 2020. Really beautiful picture, and the source is emotional processing and functional neurologic disorder review, and it was from 2019 in the Journal of Neurology. So this image is referencing that study. And what you can see here is different brain regions and the connections that have gone awry. So there's the kind of light mint, maybe I will call that color. Those are brain regions that are part of the salience network. So this is involved in finding and focusing attention. We understand attention as part of the underlying issue. And then they're in the darker blue brain regions that are part of the limbic network. So these are some of the primary circuits and emotions as well. And what you can see in kind of the beige circle there, heightened functional connectivity that they have found between brain areas. So you can see, for example, from the motor cortex to the insula, from the right hemisphere. I'm pointing at him as if you could see it on this tiny picture though, from the motor cortex to the amygdala. So there's heightened functional connectivity between these areas. I would really kind of call that some of our neuroplasticity gone awry, potentially, that has caused some of these connectivity issues. But we know that now some of these things are more common in a brain with a functional neurologic disorder. So that's why it's functional, that functional connectivity gone awry. And what we also know is that it's not faking. And unfortunately, and the author actually, the very first line in here is stop faking. And the author says, imagine hearing those words moments after you were diagnosed with something like a stroke or a brain tumor. It's totally absurd, right? And so these are the words that people sometimes hear after they experience functional neurologic symptoms. And people are not faking them. And that's what we understand from some of these, just in the last 10 years, studies on mechanisms to show that these brain connectivity issues are not what it would look like if somebody was just faking symptoms. So I think that's really important, and really important to understand how the world has changed in what we understand in functional neurologic disorder. Now, also really important is how it's diagnosed. So I'll stop sharing here for a moment. So I'm not a neurologist, so I don't diagnose functional neurologic disorder. But as a physical therapist and other clinicians that are a part of the community, we see things and we screen, right? Always, because we want to make sure what we're seeing is actually the thing. So understanding diagnosis and diagnostic criteria are very important for us. I can't tell you how many times somebody has been referred for balance and falls problems or a vestibular problem or dizziness, and it's through the therapist screening that we're discovering the diagnosis and referring them to a doctor for diagnosis. So it is really important. So when it comes to diagnosis, we now also have diagnostic criteria and positive findings. This is really, really important. Functional neurologic disorder is not a diagnosis of exclusion, meaning, well, we didn't see anything else, so it must be FND. It has positive findings. And in fact, there are repeatable patterns that are seen since early video could document them, that are very characteristic of functional neurologic disorder. So there's distinct patterns of paralysis. There's distinct patterns of dystonia and tremor. And they meet diagnostic criteria, including variability, entrainability, the ability to change with an attentional focus. Those are positive findings that distinguish FND from another neurologic disorder. But also remember that functional neurologic disorders can coexist, and they coexist commonly with other neurologic disorders. So you actually have to screen them both. So one of the things that I really, really loved about this article in Scientific American was that they talked about the stigma continuing in FND and why that occurs. And frankly, it's because a lot of clinicians don't understand it, don't know how to assess and treat it. That's why I'm here, why I keep talking about this. And a lack of support and understanding from clinicians can really lead to a strong sense of shame in a patient. And what I love most is the author, again, brings this up. This is especially true for those in a minoritized community who are already feeling the stresses and trauma of life. So a great perspective to have in understanding FND, and I think so important. I'm so thankful for the author. The author actually does research in this area, and so stay tuned, because when that research comes out, I will be sharing it with you. I think this is important for us as clinicians to think about. Now, finally, the author in the Scientific American piece also shares at the end the hope for FND, that treatment can be effective, that having a clinician who understands FND, who can provide compassionate understanding and care, a team that understands the underlying issues and can piece those out and understand what kind of treatment would be helpful for people, can truly change the life of a person with FND. And the author even says, hey, we've seen people go from functional blindness to seeing. And I appreciated reading that, because we have too. It can absolutely happen. Or from a wheelchair to walking. Yes, absolutely. And I think sometimes those are not the messages that get out about FND, unfortunately. So having a person with FND connect with a clinician that understands and can provide that compassionate care is really important. And that's honestly a big part of our mission at Reactive. My mission personally is to continue to build up clinicians, particularly therapists, that understand FND, so that literally people can go anywhere and be able to find a therapist that knows and understands it. And I think this is so important. This is why, watch out, I'm coming here almost every day. I do have weekends with my family and things like that, but almost every day to talk about FND. I would love your questions, would love your comments. I will try to respond to all of them, and we'll keep advocating. I will send a link. Let me show you the article one more time because it was so fantastic. Here it is again. I will share a link in our newsletter this week. I'll send it out this Friday to my fellow clinicians on our newsletter. You can join at reactiveeducation.com. I will send it out on Monday to our patient newsletter. You can join at reactivept.com. But just a fabulous piece. I see a couple comments here. FND tea, spill the tea here. As a person that deals with FND, even just watching your lives and seeing your posts is beyond encouraging. I truly appreciate Reactive. Oh my gosh, and I appreciate you. I gotta tell you, the FND community is just amazing. I learned so much from all of you. The other thing, Lily, hi Lily. Recently I spoke to a neuro doc about a patient who another PT and I suspect might have FND. His response was that patient needs a referral to a neurologist in psychiatry. I mean, not bad. Yes, neurology, yes, psychiatry, but that is not it. That is not the standard of care for FND. That it is not a purely psychological disorder. And I think that's actually part of what goes awry is when a person presents and instead of getting some of those positive findings and an understanding of the diagnosis, they're just like, here's a referral, go see a psychiatrist. It is really doesn't really address what's happening at all and can really lead to that sense of shame. Lily, thank you for sharing that. Referred to an OB/GYN due to weakness. The patient does not have a neurologist seeing her now, but do they need a psych referral? It's an old school thought. Now, I gotta tell you, when somebody has been through FND and through a lot of, frankly, this kind of medical trauma, psychology could be really helpful because they've been through a lot. And honestly, in our integrated team, we find psychology very helpful as a member of the team, particularly to help us integrate and understand those brain body connections. But just psychology, I believe that's a totally old school thought. PT, OT, psychology, yes. Betsaida says a detailed eval is so important. Any tips on how to make the process more efficient? I'm right there with you, Betsaida. I love a very thorough assessment, getting at all the underlying pieces. It's very rare I get it done in one session, and I'm scheduled for an hour with a person. And so I am a firm believer in the patient is my guide. I listen very closely and I have them take me to the most important pieces. So I know Betsaida is a part of our community, so she knows the pie chart. By the way, I will definitely share about the pie chart in the coming months. We kind of use this pie chart framework to really decode what the person is sharing in their story so that I can go to one or two pieces initially. And that's how I become efficient. So the person might be sharing with me and I get hints and clues about autonomic or sensory issues. And I'm going to go to those pieces and get that piece first. And I might get to other pieces as well, but I'm gonna get to the pieces where the patient tells me to go. So I become efficient by listening really, really well. I don't think I'm like an extra good listener or have fantastic ears, but I pay very close attention to the person in front of me. And that makes my evaluation very efficient. So that's such a great question, Betsaida. I'm not trying to say it's easy at all. I do think it's really challenging to do a really thorough evaluation quickly. And I think that's why we need time. I think FND is really tricky to treat in a model where you have a patient every 15 minutes. I wouldn't be able to do that at all. And I don't think that's a good standard of care in physical therapy for FND. So thank you so much for joining me tonight. Get ready. I'm coming at you again tomorrow. We're going to keep talking about FND all month. Grab this great article from Scientific American, New Research Points to Causes for Brain Disorders with No Obvious Injury. It's such a great review of FND. I would share it with patients. I would share it with my fellow healthcare providers. I'm sharing it with you all right now. And I hope you find it helpful. Thanks so much for joining, for advocating with me. I appreciate you all, and have a good night.